Good afternoon. My name is Dr. Sean Kraekel. I'm an orthopedic surgeon. I specialize in hip and knee replacement and revision of those same joints. Thanks for taking time to listen to me chat. I basically thought, what do people typically want to hear from me? And that's how I came up with the topic of considering joint replacement and just talking about the steps to take before surgery. Just a little bit about me. I'm based out of our Springfield and Alexandria offices with OrthoVirginia. And again, I do predominantly a majority of my practice is hip and knee replacement. I was in practice in Houston Methodist for several years before coming here a little over a year ago. What I would want you to know, and kind of the main thing people ask me about when they come, is it time for surgery? What should I be thinking about? A lot of the time, someone knows someone who's had a joint replacement, whether it be a hip or a knee, and they're sort of trying to figure out, I've been aching for a while, or this is the first time I've really had an ache in my respective joint. How do I go about managing this? So, first off, a lot of people know to reach for maybe an Advil or Aleve, and that's obviously assuming that you're not allergic to those medications, don't have contraindications, meaning reasons you can't take it. If you have kidney problems, you can't take those kind of medications. If you have a history of stomach reflux, those tend to make it a little worse. Better to take them with food. But if those don't bother you, then a lot of the time, if you see your primary care or one of us, that's going to be one of the medications. We can even prescribe something. It's called a non-steroidal anti-inflammatory drug. And we usually will do something similar to those, like Advil, similar to the Advil Aleve, but in the prescription dose, so a little higher dose than what you would get over the counter. You can also typically take something like Tylenol with that as well. Medication, again, those are things you can get over the counter, but we might suggest taking a little higher dose. Generally, we try to stay away from anything that's an opioid medication. That tends to make pain management during surgery, after surgery, a little harder. And so you're actually going to experience more pain after surgery if you're taking opioids to manage your pain beforehand. And it's been my experience that opioids don't really manage arthritis pain the same way as it might post-operative pain. I often encourage people to not take them if they already are, if they're trying to manage it. And honestly, a lot of the time people say, oh, that didn't really work for me that much anyways. A common one that we use, which is a weaker opioid, is called tramadol. And that is an opioid. Some people are surprised to hear that, but that is one that I usually try to steer people away from using to manage arthritis just because it doesn't work quite as well. Other things that I usually recommend are more, what can you do to make your knees not hurt as much? I always tell people, it's a lot easier said than done, but trying to keep our weight down is something that can help to reduce weight and force that's going across our joints. If they have bone-on-bone arthritis, which means that really what is arthritis, it's the cartilage has gone away. And so the cartilage is a nice thin layer of kind of cushion that goes over the bone. If that gets worn away, you're really going to have what we call bone-on-bone arthritis. And when that happens, there's more force every time you take a step. And when you go up and down stairs or get up from a low chair, that's going to hurt more because you're putting more force across your knee or hip when you're trying to get up from those positions. And it's putting about 4 to 5 times your weight across that joint. So it's important to know that, even a pound of weight loss could be exponentially better, 4 or 5 pounds off those joints that hurt. And so it can take not a whole lot to make that less painful. And also 5 pounds of gain can actually be pretty significant for what hurts across those joints. Likewise, you can easily take some weight off of those joints by utilizing either a cane or walker. I usually get a dirty look if I suggest those because that's kind of, unfortunately, it can be associated with maybe aging and things like that. I usually suggest also some walking sticks, hiking poles if you go on a walk. I think those are a little more palatable. Also, they work better, I think, because you stay a little more upright when you're using those versus leaning over with a cane. One thing that a lot of people don't know is that a cane should be used in the opposite hand of the hand of the joint that hurts. So if your left knee is what hurts or your left hip is what hurts, you would want to use your right hand and vice versa. That tends to be just something that people are surprised by because I think the tendency is to try and hold a cane, for example, in the side that hurts. But it actually allows you to lean away from the side that hurts when the opposite hand is holding that assistive walking device. Physical therapy can help. It can help you build up muscle. It is not going to change arthritis. It doesn't make you gain any cartilage. It just can help you feel a little bit better. So those are things, but I do think it helps you get stronger so that also after you go through surgery, and you're going to be weaker after a surgery temporarily, because we're going to, spend some time rearranging your leg, and it's going to be achy and sore for a while. And so doing some therapy and at least some exercise ahead of time is important. And I think that also, similarly, with therapy, you're sort of building a brace out of your muscles around the knee, and you're trying to create that. Alternatively, you can wear a brace. I will say, as a little disclaimer, sometimes wearing a brace can push down on the kneecap, and some people have predominantly arthritis under the kneecap. That can be pretty painful because it actually just pushes on it. So when you're getting up from a chair or going up and down stairs, that can aggravate it. It really depends on how unstable your leg, if a brace is going to be that much help. And then besides braces and things like that, I do just think trying to stay active. Running is pretty harsh on our joints, so generally trying to find an alternative, whether it be cycling or walking. Those are things you can do. And then when you see us in the office, we might offer you a steroid injection. Those are tried and true, work very well. There is some data that might suggest that if it could potentially be a little damaging to get steroids on repeat for extended periods of time, it may actually lead to some cartilage wear, but that isn't definitive. There are some studies that show that, but I will say, if someone's already in the bone on bone stage, the next step, you've already lost a lot of the cartilage. And I have seen people, get a little bit of relief from that. It's typically not going to totally curb the process or prevent you from going on to surgery, but it may get you some time so you can work on physical therapy, again, strengthening your legs so the recovery is a little easier. It also may be something that allows you to just get a little more time. Say, your example I often give is a teacher, and the summer is what you need to get to have surgery. Well, maybe a shot is something that can help you get to that time. The other thing I would say is there's gel shots. Hyaluronic acid is the main ingredient in that. People used to refer to them as rooster comb, because that's where the hyaluronic acid would come from. Those are shots that can only be given about every 6 months, and they have to be approved through insurance. They're not proven to be any better than a steroid shot, and in many ways have actually not shown to be as efficacious in some cases. So our national societies don't recommend, or actually recommend against, routine use of the hyaluronic acid or gel shots. However, I think if people want to try everything short of surgery, it's not unreasonable. It's something worth talking to. Sometimes there is some added cost to those, and so I caution people, if you don't get any relief from a steroid, it's very unlikely that you're going to get sufficient enough relief from the hyaluronic acid. Something I didn't mention with the steroids is we can usually repeat those after about 3 to 4 months. And the medicine usually lasts 3 to 6 months, ideally. And when people have told me they've had relief for years from a shot, it usually just means they didn't aggravate the arthritis again, and they've been at a relatively good, steady state. The medicine's probably not there anymore after about 3 to 6 months. Those are the things that you can do. Just very briefly, people talk about other shots that are investigational, like platelet-rich plasma or stem cells. I would say that those are very investigational at best. They're not necessarily proven to not work. They're probably safe to try, but they're pretty costly. And the data for arthritis is not very compelling that those are worth doing or spending a lot of. I would recommend, if you go that route, which some people want to try everything short of surgery, I would typically not expect it to work. Meaning, if you're going to do that, I would be willing to know that, hey, I'm going to spend this money, and if it doesn't work, I'm okay with that. And just disclaimer, I typically don't perform those shots because of the opinion I just voiced. But again, I think that they're available in our practice, and they're not necessarily a bad thing. I just don't think people should have for severe arthritis, bone on bone arthritis, it hasn't been shown to be very efficacious. Mild cases, that is more promising, and I think worth entertaining. Those are the things you should do sort of short of surgery. If you can't do the things you want to do, you hurt, you're unable to really enjoy life, and you've done those things and you're starting to lose activity, that's when people should pull the trigger on surgery. I really do feel that surgery is a good option, whether we're talking about a partial knee, a total knee. or in the hip, doing a hip replacement, the surgeries work. They give you a new knee, and they are different than the knee that you're born with. They're different than the hip that you're born with. It feels a little different. But generally speaking, people have significantly less pain. They're much more active, and if you're losing activity despite all those things I just listed doing, that's when I would pull the trigger on surgery. Now, what I will do, and I know there's a lot of good questions coming through, so we'll get to those soon, probably in about, I'm going to talk just briefly about sort of, all right, you've decided it's time for surgery. How do you really plan for that and optimize the chances of that going well? Well, if you're found that, despite doing all those things that I mentioned earlier, you can't stay active enough, you've changed your activity and you can't really find an alternative. Running was your hobby. Now you can't even go for a short walk without severe pain and kind of paying for it the next day, and you're taking medication to do it. I think that is when I would nudge someone to consider surgery. And obviously medically, we got to make sure that you're as healthy as can be for surgery. So we often get some clearance letters from your primary care, maybe even a cardiologist. And some people have some medical conditions we have to consider as well. And so sometimes we have to counsel with some other providers. If someone has diabetes, there's a lot of data suggests that as the A1C, which is one of the markers of a high, having controlled or uncontrolled or modestly controlled diabetes, as that number goes up, the A1C, as that goes up, so does the risk of infection. Infection is really a dire thing that every joint surgeon it's a miserable experience for the patient, so we are a little crazy about it. A couple of things I'm going to tell you are how we prevent infection, and a lot of it's the best way to not have an infection is some steps we do before surgery. So again, that A1C is a marker of how well your diabetes is controlled. We want to keep that below 7. Below 8 is okay. I told my patients I want it below 7. I generally have always been able to get patients to get it below that, and sometimes it requires working with an endocrinologist. Every once in a while, someone has severely refractory diabetes. Sometimes we have to work out an alternative, but I would say most patients can get it below 7, and that makes your risk of an infection just about the same as someone who doesn't have diabetes. Weight is also a risk. So, some patients may have had the experience where they see a doctor and they say, well, you got to lose weight to have surgery. I think the big takeaway that I don't think every surgeon takes time to explain is as weight goes up, so does the risk of infection. There's very good data that shows that as BMI, which is a ratio of your height and weight, as that goes up, the BMI goes up, so does the risk of infection. And it's a fairly slow rise until a BMI of 40, and then it starts getting exponential. And so what I encourage people to do is think about it this way. If you can get off of this curve and get your risk down to, from 10 to 2, you're going to be a much happier person and much lower risk of infection. So I recommend people get their BMI under 40. It's not an easy thing to do. And obviously, if you can, get your weight even lower, that's great. But the biggest thing is you want to be on that lower curve, which is generally at a BMI of 40 and lower versus being on the higher end of that curve. And I'm realizing there's a reflection, so I should probably be going this way for the audience. But the point is, as weight goes up, so does the risk of infection. And so and that's really because the layer of adipose tissue or fat cells doesn't have as good a blood flow. And so that means that those areas heal a little slower. And from the moment we do surgery, it's a race of your incision healing and bacteria that naturally lives on your skin and my skin and everyone's skin. It's a race between bacteria that naturally lives on your skin getting into that wound and the wound healing. So we want to optimize the chances of it healing. Diabetes prevents that. High weight can be associated with that because of the slower healing of that adipose tissue, that, as I mentioned. And then also smoking is a risk too. And I really tell people it's not just the act of smoking, it's nicotine itself. Nicotine is a vasoconstrictor, which means it constricts your blood vessels. It actually makes it harder for healing. So I usually recommend trying to reduce nicotine use for the first 6 weeks before surgery. Ideally, we actually ask people to not quit smoking and actually to continue that for 6 weeks after surgery, because nicotine stays in your system that long. Those are all things that, for someone who is an active smoker, that's obviously something to be thinking about when you're considering surgery. because you're gonna have to work on that. That's not something that you can do often with a flip of a switch. Granted, I will say I ask every patient who's done it how they did it, and the overwhelming majority that have succeeded have told me they just did it cold turkey. I'm no expert on it, but I've heard it from probably 100 people now. And so those are things you should be thinking about. Lastly, I would say timing, and I did see that a few people were asking about timing. If I plan for surgery, I tell people the recovery is about 4 to 6 weeks for you to feel better than when you started. I mean, you come in, you're in pain, you're not moving that well. We're going to do surgical pain that may be a little different than the pain that you've experienced from the arthritis. It actually might even be worse. I would say for knee replacement, we're asking you to walk and move the thing that we just operated on, which is a lot different than having like your appendix out. We're asking you to walk on it and bend it, and that means it's going to hurt. The key is that you want to make sure that those things that you basically, that can cause pain. And so the key is for 4 to 6 weeks, I wouldn't plan any major family trips, or if you have anything that you really need to be ready for. Sometimes that would be a factor, or if you need time off from work. I tell most people if they have a desk job, they can usually return back to work within 1 to 2 weeks. If it's a more laborious job, they usually need 4 to 6 weeks, especially if they're climbing ladders or doing some sort of maintenance thing. I usually recommend 6 weeks for that. Everyone's a little different. There's also a timing for driving. You usually cannot drive for 2 weeks after any joint replacement, but for the right knee, I typically recommend 6 weeks. And that's because there's a study that shows that your braking time is delayed. Meaning if I flash a red light and you hit the brake, and it is delayed for up to 6 weeks in some people. About 20 to 30% of people, it can take up to 6 weeks. So for the right knee, because that's the leg you're driving with, unless you're driving a clutch, and then that actually involves the left leg as well, that would also extrapolate to that. Those are things that patients should think about. And then I do tell people, if you're going to plan a trip to like Europe, we're going to walk on cobblestone and want to be happy, give yourself 3 months from the surgery date so that you're not thinking about surgery, you're not thinking about your knee or hip. That gives you ample time to recover, and you still will feel even better over the coming months after that. But at least the first 3 months, you will be a happy person, not thinking about that joint very much when you're on your trip. Those are the things I think are critical for sort of thinking about the timing of surgery, things you should do before. I'm sure there's some other things there's plenty we can always talk about beyond that point, but those are the main things I would want you to think about when people are saying, well, all right, I want surgery. How does this work? We can usually do it pretty quickly once we get our clearance letters and things like that. But sometimes it should work with your lifestyle too, your quality of life, your ability to have your help as well. So a lot of the time people can get up and do stairs the same day of surgery. 90% of my patients get up and walk and even go home the same day. But you're not cruising. You're still going to be a little achy and sore. So it's helpful to have help at home. Everybody I see, I'm asking, do you have help at home? Do you have someone who can help you? Most people do go to their home, or maybe if they have a third story townhouse with all stairs, and they have to do several flights to get to any room, not just the bedroom. Sometimes people will stay with a family member even for a few days, just not because you can't do stairs. It's just it's a little less stressful on your soul. It's a little easier. And then the other thing is, I think just making sure that you have help arranged, whether it be a family member or a friend. For that first week, it's someone who we call a coach, but someone who can help you keep track of your medicine. We do a lot of non-opioid medicine, at least in my hands, I do that. So it ends up being a number of pills to keep track of. We also give opioid medicine, but to try and reduce how much of those meds that you need to take, it helps to take simple things like Tylenol, an anti-inflammatory, a muscle relaxant, and that helps you reduce the amount of opioids you take, which the reason people used to stay in the hospital for a number of days was they were frankly asleep in bed because they took too much. We used to give people too much opioid and you would fall asleep and be nauseous. And now we've learned from that. So those are the main things I think people should know. And I think for questions, we can try to start addressing those. I think, let me see if I know Margaret had some questions.
So our first question is, how long do the implants last for a joint replacement?
That's a great question. So I get asked that pretty much every day. I would say the general rule of thumb, we know that for both hips and knees, 95% of the time, these implants are lasting about 20 years. You're going to get a mixed message potentially on who you talk to, because if we believe that the equipment that we're using now will last longer than that, because we've improved the wear pattern. So when you do it in a laboratory, the plastics that we use that are part of the implant should last 10 times as long as they used to. So we suspect it will be more than 20 years. I still tell people to plan that it could be up, around 20, just because that's what we have data for. The implants with the newer versions of bearing surfaces, which are what we're using, whether it be metal or ceramic or plastic, the current wear pattern will last. I've had people where I've revised them and they had their surgeries, say 27, 28 years ago. And that was a earlier, kind of the closest to the versions of equipment we're using now. So I do think you can plan for it to be longer, possibly. But I tell my patients to plan for 20 years. If you're in your 40s, which is rare, but I do have patients even younger than that, you need to think about that. And I might use implants that should work and last just as long, but on a smaller size, so that revising that, keeping a little extra bone, so that making sure that the revision, should it be necessary in the future, won't be a challenge. I do a lot of revision surgery, so I think about that significantly when I'm doing these surgeries, because, and not revisions of my own, I'm talking about patients who had their surgery 20 years ago. They need to be revised. I try to think about that for the patients I'm doing their primary surgery on, but I would say about 20 years.
And so you touched on this a little bit, but how do you choose which implant you use? We had a couple of questions of, are there specific implants for athletes versus non-athletes, or does it go by something like anatomy?
It's a great question. So I think you might get, the same answer from just about every surgeon, but we all might use a different implant. And so part of it is sort of what implant you think can give you the most accurate outcome for a patient, that you think can achieve it. I think that there is different philosophical reasons that some surgeons might use one implant over another. But in terms of where, I would say I try to use the implant, no matter how old the patient is, I pretty much use the same equipment, because I want something that's going to last a long time and do well. So for example, when we talk about hip replacements, we're typically using implants that are made out of titanium, that matches sort of the normal. Our bones actually have a little elasticity, and titanium is similar to that. It's also an inert metal, so people don't really have a sense of, there aren't really a known allergic reaction to this type of metal. That's one of the reasons we like titanium. It matches what we call the modulus of the quality of the bone, and so it integrates with bone very well. And so hopefully, as I was alluding to revisions in the last sense, we utilize implants that have textured, and again, talking about a press fit hip replacement in this case, the bone can grow into and onto that implant, and that will hopefully be an interface that lasts long beyond 20. Often what we're trying to revise in those settings is the interposed bearing surface. So again, I have a model here I could show you. This is a hip replacement. We have metal titanium stem that goes into the bone, and a metal titanium cup that's actually a hemispherical shape at the base of this. But then in the middle, we have a ceramic ball that integrates with a high molecular weight, highly cross-linked polyethylene, which is a fancy plastic, and we have found ways to make that plastic wear at a rate of about 1/10 of what it used to. And that used to be the primary failure point, and that is often the things that were put in 20 some odd years ago that I'm revising for. But in terms of athletes, I do sometimes err towards a slightly larger ball. The wider the ball, there is a risk of that wearing out the hardware faster, but it will allow for more mobility. So I have someone who is in my practice who is an active like karate master, and he does, he, despite me asking him not to, will do splits in front of me. And so I did use a larger ball in his case because it has a lower chance of dislocation. And I knew he was going to be doing these exercises and things. So I had to make sure that that was not going to be an issue for him. He's had no dislocations or risk from that. But there's certain things I will do differently, maybe, but with a conversation with the patient, because it often, in that case, there is a potential risk by using what we a slightly larger ball, that you have more surface area and you can actually wear out the plastic a little fast. So that's sometimes a discussion, but things that I would have that discussion with a patient if we thought their activity level might mandate more flexibility, but maybe we need to be prepared that hypothetically that could wear out a little faster. Again, the plastic we use is what would have worn out, and the literature suggests that that may not be the same with the current plastics that we're using, but hypothetically it could be a problem.
Can you clarify that when you're talking about things generally and you're not giving a specific example, it's the same information for hip replacement and for knee replacement? So for example, needing help at home for a little bit afterward.
Yes, that is that aspect of my advice, everything I said for even the managing the arthritis before surgery is identical. The one thing I will say is hyaluronic acid is not as commonly used for hip injections, but we mentioned those gel shots, that's typically confined to the knee, and same with bracing. Bracing is generally more for the knee than the hip, but every other aspect of before surgery that I talked about is identical besides that. And then for after, in planning for surgery, those risks for infection are also borne out in the literature, almost identical, which is why we think those numbers for BMI, A1C, and also nicotine use are all, they bore out identically with hip surgery and knee surgery. So we know that those are risks that are repeatedly shown in the literature for different joint replacements. And then in terms of the recovery time, I do believe it's about 4 to 6 weeks. The hip tends to be an easier recovery. The knee replacement, I would say the first 2 weeks, if you had both surgeries done, I think anyone who's had both done would say that the knee replacement is a harder recovery than the hip. And mainly that's because the knee gets stiff a little more easily than the hip. And stiffness in the knee is more challenging. You need to be able to get your foot underneath you when you're in a chair. You need to be able to get your foot underneath your body to get up from a chair. And so things like that, you really need to have more flexibility with the knee than the hip. And so patients are going to notice that more, and we're asking you to really work on range of motion early on in that process, which I think is where people experience more discomfort. So there's literature that shows that on average there's a higher opioid utilization among patients undergoing a total knee replacement relative to a total hip replacement.
Can you describe what you mean when you say that the replaced joint feels different from the joint you were born with?
Yeah, I think that's a great question. So biomechanically, we are replacing a part of your body with an artificial piece of equipment. And so the beauty of our human body is we can heal, and cartilage doesn't heal very well, but most of the other tissue does. Metal and plastic and ceramic do not heal. And so they have to have slightly different properties and just naturally do than what you are born with and have. I do believe that the hip replacement mimics the native anatomy a little better because it's a ball and socket, and that is a little easier to replicate than a knee, which is a hinge joint, and our knees are able to bend as a hinge, but they also have a little side-to-side play, which we call varus valgus, and some rotational movement. So a door hinge is just a simple hinge, but a knee joint is different. It actually has these other ranges of motion as well. When we replace the knee, and again, there's a lot of different philosophies around it. I often do one that I try to make sure that the knee is a little looser on the outer side of the knee than the inside, because that's how our native knee is, and I try to mimic your normal anatomy as much as I can, and I use implants that allow me to do that. Even more so, I think that one of the big takeaways is that it's made out of plastic and metal. And so if you swing your leg off the bed, there'll be a little click. And your knee may click with arthritis, but it feels a little different with the plastic. And so I think that throws some people off. You have an ACL that some people get replaced or reconstructed in their native knee. We cut the ACL out when we do a total knee. When we do a partial knee, we're able to keep those ligaments, the ACL. And sometimes we even take the PCL for total knees. We take that out or we don't have to take that out with a partial. Partial knee has all of the ligaments maintained, and I can tell you that people feel, all right, there's a little higher satisfaction when you look at national data with partial knees relative to a total knee, and that's because it feels more normal, feels more natural. There's a little more of the natural feedback from that knee than from a artificial knee that has replaced some of those ligaments. The knee is still as stable because it mechanically allows for stability through the mechanism of the implant, but it just feels different, and patients say that. And so I think it's important that patients know that. It's not more painful, and I think anyone who's got a painful knee that you can't do the things you want to do, that the benefit of a knee replacement makes you significantly more functional, restores the alignment of the knee. It helps it work really well, but it is not the knee that you're born with. And so, if you were to go try to do cutting sports like soccer, you don't have as much of a feedback. Proprioception is the word we use, which is awareness of that joint when you're doing sort of a fast pivoting movement in those knees. Doesn't mean you can't do those, you can try to do things, but I do think that those are things that I notice with patients. And this is, even when I was in training, plenty of great surgeons who I've heard that repeatedly. I don't think, and so I think it's important for patients to know that it just feels a little different. And there's different styles of knee replacements, for example. Some are intended to have a different mechanism, like a cam and post, which I don't use, but when we use that, it clicks a little bit more. It's called a PS knee, and so it's posterior stabilized knee. And that typically can click a little bit more than the cruciate retaining knee, which is what I typically use.
Do you do robotic knee replacements?
I do. I have a lot of experience with robotics. I had my fellowship, one of the lead designers of one of the top company, really the longest standing robotic on the market. He was the lead designer for the total knee for that system. So I have extensive experience for robotic joint replacement. I've been credentialed to do robotic hips and knees and partial knees, really for extended since I was in fellowship, and so over the last 6 years. I actually introduced robotics when I was at Houston Methodist. I was one of the first users. They did not have them when I got there, so I got them to incorporate robotics at the hospital and ran the robotic program at the hospital I was at. So I actually have a lot of experience and do them routinely. And really kind of comes down to what the patient wants and talking about the pros and cons of whether or not robotics is there. I do think one thing to know is that robotic joint replacement it's a technique, it is a tool. And I think if you go to someone who doesn't have robotics, I'm sure they do a very good job with their joint replacement. I still do some without robotics for various reasons. And I do think that the key is, knowing that it's a tool. And I believe that the benefit of robotics is it adds precision to the surgery. It allows you to very precisely reproduce the plan that you want. And you can also get some intraoperative data from that. There's also some navigation tools out there that allow you to gather some of that same data, just in a different way. But the key is we're getting to a point where now in the operating room, we talk about a difference of a millimeter, where implants used to not even, you would be worried about 2 to 4 millimeter difference. So it really has honed in our precision, I think, in the operating room, where we're as a surgeon, I think, that much more aware of accurate, not just accuracy, but precision. One caveat is if someone doesn't have a lot of experience with that, I think it's important, you don't want to demand it from someone who doesn't do it often, because I do believe there is a learning curve with those technologies. It's been shown, and at the same time, it's a tool. And so I think, if you're in a place where you don't have access to robotics, that's not actually the end of the world. It's a fancy saw is kind of what I tell people. That said, I subscribe to it. I think it's a good technology, but I also don't think that it should make or break outright, people's decisions.
Thank you so much, Dr. Kraekel. That is all the time that we have today. Would you like to close?
Sure. I know there were a lot of other questions. I don't know if, I'd be happy to try and give, maybe at some point I can answer those as well. I really appreciate everyone coming out to listen to this. And I know that there's probably a million great questions that we didn't get to. And I would, I appreciate your time. And, I'd be happy to see anyone or counsel you. And again, I just hope that patients, it's an overwhelming decision to undergo a joint replacement. I think the key is to you want to know, hey, you've tried things before you make the decision to do surgery. And if you do take the steps to do a surgery, planning out that time, don't rush into it. Make sure that you feel comfortable with, the surgeon, the approach, how they're doing it. There's a lot of other things we could have got into today about like approaches for hip replacements, things like that. I appreciate your time. Sorry, we can't, there's so much we can talk about. So thanks again.